let us
Start.
All right. So who has been to the ER thus far and has seen some sort of trauma? Blair, Nicole, Isabella, all psych patients. All right. Give me some examples of some traumas that you've seen. Hit by a car, pedestrian versus auto. Okay. Gunshot wounds. What else? Fall. Okay. Burns are a form of trauma, right? We just learned about those. In your colder states, frostbite is a big form of trauma. Places like California and Hawaii, shark bites are a form of trauma. So kind of thinking along those lines. So here's general terms for you to know when you're going through the trauma assessment. So to start, we have your trauma triad of death. Okay. So little triangle there, 3 points. You got hypothermia. So we want to prevent hypothermia in your trauma patient. Does anybody know why? Say it again. Increase that metabolic demand. It causes that vasoconstriction. That vasoconstriction causes a decrease in the oxygenation to the tissues, causing that increase in the metabolic demand. Increase in metabolic demand causes, starts with an L, lactic acidosis. What lab can you assess to check for lactic acidosis? Lactic acid, right? So, bless you. Both of those going into and causing coagulopathy, meaning this hypoperfusion and this metabolic acidotic state is causing issues with the patient's bleeding status, meaning they're either high risk for bleeding or they're already bleeding and we're having a hard time controlling it. Okay. So main goal with trauma is to prevent hypothermia, or if they're already hypothermic, warm them up to prevent further damage. Okay. So 4 general types of trauma. You have penetrating. What do you think penetrating traumas are? Like anything that breaks the skin. So it could be a stab wound. It could be a human bite, an animal bite, a shark bite. When your bar fights come in and somebody threw a knife and there's a knife sticking out of the arm, that's a penetrating trauma. What about your thermal traumas? Burns, frostbite. What's another one we don't necessarily think of because there's no external damage? Okay. Heat stroke, heat exhaustion, right? And then and then what about your blast injuries? Right. Which we'll talk about in a minute. Your explosions, and then we have your blunt traumas. Okay. So penetrating trauma, as we said, anything that penetrates the skin. So gunshot wounds, stabbing. What do you think these patients are at high risk for developing? What type of shock? Hypovolemic, right? And then when you have this foreign body here, what other do you think they're at risk for? Infection, sepsis, right? So when you have a penetrating trauma and you have, say, this guy here with a knife sticking out of his chest, don't pull it out. Thank you. What do you need to do? You have to stabilize it, right? So sometimes we forget any of the small things, especially around in Statesville. Can't tell you how many times I've seen people come in with a fish hook stuck in their hand. And it's little, we think, oh, we can pull it, whatever, no big deal. No, stabilize it. They've got to get some x-rays to assess that area first. And then the doctor will determine if it's appropriate to take out or not, or if they need to be transferred to a bigger facility and maybe have it surgically removed. So do not pull the penetrating item out. Stabilize it. Okay. What do you think you're going to give them because of the high risk for antibiotic or high risk for infection? Antibiotics. Right. Okay. And then we're also probably going to give them what? Tetanus. Huge. Could, depending on that coagulopathy, if they're where they are on that triad. Fluids, depending on what their vital signs are. Blood, if it's a massive penetrating trauma and they're losing blood. So what kind of vital sign changes do you think I'm going to see in these patients if they're losing blood?
Low blood pressure.
Decreased blood pressure, increased heart rate. What do you think is happening with their cardiac output? Not very good, right? So do you think it's going to be kind of hard initially to determine if they're in septic shock versus hypovolemic shock at first?
Yeah.
Maybe, right? Because they're both going to have that high heart rate. They're both going to have that low blood pressure, but determining, hypovolemic versus sepsis may be a little hard in the beginning, especially if it has been a while before they come in. A lot of times when people get a gunshot wound, they do not come into the ER immediately because gunshot wounds and penetrating traumas are required to be reported. People think they come into the ER with a gunshot wound that they're going to be the ones to get in trouble. We don't ask any questions like that. We just call the law enforcement to come take care of it. So if they got shot yesterday and they're just now coming in today to take care of it, it may be hard to tell. Did they lose volume and we need to replace it? Or are they starting to have an infection develop because of that 24-hour delay in care? All right, so now we have thermal trauma. So thermal traumas, like I said, are going to be your frostbites. Think heat stroke, heat exhaustion. We don't really think about those, but it's a form of thermal trauma. And we'll cover those things in your environmental and toxicology emergencies. Think back to burns, anything Ms. Joy covered last unit's fair game, because it is a form of trauma. Somebody said chemicals. So chemical contact, like if you were to get bleach on your skin, a hazardous chemical direct contact, that is a thermal trauma. And then radiant heat, somebody said, if you are cooking and there's a massive amount of steam that comes up and you get a steam burn, that's a thermal trauma as well. And that's what we're going to cover there. All right. So blast trauma is related to or causes injuries created by an indirect or a direct explosion or exposure to an explosion. So we all know bombs, IEDs, grenades cause blast traumas, but what other forms of blasts do you think of? Huh? Fireworks. Okay. I mean, it's summer, 4th of July. What else? Propane. Gas explosions in general.
Fires, like brush fire, like you pour gas on it.
Mm-hmm. Right. So sometimes you can have more than one type of trauma. You can have a blast injury that causes a thermal trauma, if that makes sense. So another form of blast injury in the area we've had a couple of, more Rowan County, are your meth labs that explode, right? You have those chemicals that create an explosion that create that blast effect that happens, right? So thinking of your types of trauma, let me cover blunt first. So blunt is probably the most common that you'll see. It encompasses a little bit more than the others do. So blunt trauma is caused by your forceful impacts, usually like your falls, or like a physical object that hits against something, that creates some sort of mechanism of injury that creates the injury. Meaning, say I'm fighting with Justin and he grabs a golf club and swings it and hits it at my head. That's a blunt trauma. That object hit against my head, causing that blunt force to the back of my head. Okay.
You repeat the whole cause.
Forceful impact. Or it's caused by forceful impact.
Okay.
Whether it's a fall, an object, something that creates a mechanism of injury or energy that creates the injury. So a common form of blunt trauma that we see in the elderly are your assisted living patients who maybe get up, or even patients in the hospital, they get up to walk and they fall and they hit their head on the ground, right? It's a form of blunt trauma. What other forms of blunt trauma do you think there may be?
Okay.
Car wrecks, right?
So,
Assault, using like a fist, right? So in car wrecks, how do car accidents cause blunt trauma? You got your seatbelt, right? So you got a seatbelt sign. Who knows what a seat? Who can tell me what a seatbelt sign is? Right. It's that red. It's either a red or bruising mark that goes across your chest, and sometimes it goes over the abdomen, depending on how hard the seatbelt pulled. That could possibly indicate bleeding. So you think blunt trauma that way. What about if your chest hits the steering wheel? Is that a form of blunt trauma? Right. What happens if you're clumsy and you run into doors? That's a form of blunt trauma, right? So we think trauma, we think this massive, horrible injury, but we don't think about just the simple things that cause injury. That's also a form of trauma as well. Okay. So, wrong button. All right. So when we do our trauma assessment, we're going to do what's called a primary survey. Okay. For a trauma assessment, our primary survey is A, B, C, D, E, F, and G. Okay. A lot of alphabet to remember, right? So A, airway. What do you think I'm going to do if I'm starting out with the airway? Open it. Make sure what? Make sure it's patent. If somebody's talking and vocalizing, what can you assume? That their airway's open. If they're gurgling or gasping or not doing anything, then they probably don't have that open airway. So you want to make sure the patient's airway is established. Do that jaw thrust maneuver to open up that airway if needed. You want to make sure that neck is in a neutral alignment. Tying in with Miss McCarg's, make sure the C-spine is in alignment to prevent further injury if there already is one, or to prevent injury at all if there's a spinal cord injury. So general rule of thumb is if your patient's spontaneously breathing on their own, we'll do a non-rebreather. If they need ventilation support, we'll do a bag valve mask. And then if their GCS is less than 8, then we'll go ahead and intubate. If their GCS is less than 8, if they're not responding to painful stimuli, if they are unresponsive, they're unable to protect that airway adequately by themselves, so we need to give them an airway. All right, so I established an airway. Now we're going to take care of their breathing. We're going to see if that jaw thrust maneuver worked, how they're doing with the non-rebreather, how they're doing with intubation, and our efforts that we did worked. So what are some things that I want to assess? Breath sounds. Okay. When I'm listening to breath sounds, what am I determining the presence of? Are they there, right? If they're not there, or if they're absent on one side, what could be present? a pneumo, okay? All right, so breath sounds, crackles, maybe it's fluid, maybe it's blood, depending on the type of trauma that's there. When I say lung expansion, what do you think I'm indicating in regards to trauma? Flail chest. Do I have that paradoxal chest movement? Do I have normal chest movement? Is only one side of my chest rising and falling and the other's not? What about respiratory effort?
Well, I have a question about that.
Is it good? Yes. About what? Sorry.
Breathing.
Okay.
So, in 215, you were taught that if someone is not breathing, give them a non-breather and wait 20 seconds. If they're still not breathing, then start doing things. So if they're doing that, that's what we actually taught the physician.
I'm not familiar with that, so no. Just go by what I tell you. Respiratory effort, how well are they breathing? Are the interventions that we're doing, is the intubation helping their efforts? Not only that, but are the rescuers who are bagging your patient or ventilating your patient, are they doing what they're supposed to do as well to help those respiratory efforts? Are there shallow breaths? Are they labored breaths? Are they Kussmaul respirations? What kind of respiratory status are they? And then presence of trauma. So what do you think I mean by that? Right. Anything obvious? Is there a penetrating trauma that they have to their chest? Maybe they were hunting and they got shot by a bow in the chest. Is there anything obvious that's compromising their breathing and respiratory status? So once you assess both of those, you're going to move to circulation and you're going to move to the control of hemorrhage. So you're going to make sure that your oxygenation efforts, ideally, if I'm improving your oxygenation efforts, I should be improving your what? Your cardiac output, your perfusion efforts, right? So I want to make sure that I'm doing that. I want to see if there's a threat to my patient's circulation. Give me an example of how I could, or what I could assess that would be a threat to a patient's circulation. Hemorrhaging, right? Maybe they have a massive gunshot wound to the chest and they're just hemorrhaging out. Maybe they have a shark bite and they're traumatic amputation from it and they're losing blood. If I have a threat to circulation and I'm hemorrhaging and I have the ability to, what is something that I could place? A tourniquet. Where do tourniquets go? Above the level of injury. Can I put them on the chest or the abdomen? No. They only go where? On limbs, extremities, right? If I have a hemorrhage or a threat to circulation that I'm not able to use a tourniquet on, what do I need to do? Apply pressure by doing what? By packing the wound. So pack that wound, apply pressure, not like, I don't want to hurt you, but like put all your body weight on that to help try to get it to stop bleeding. Okay. So how could your respiratory status affect circulation? Say you don't hear breath sounds on the left side. How would that affect your client's circulation? Mm-hmm. Decrease venous return, decrease cardiac output, right? So you think their pulses are going to be strong and bounding or weak and thready? Weak and thready. Okay. We talked about the obvious external hemorrhage, applying the tourniquet. So palpating the pulses. What are my pulses? What are the pulses to the injury that's distal? If it's not a traumatic amputation, assess what your pulses are distally. If you get shot in the thigh, I want to see what your pedal pulses are, as long as it's still there. And I want to monitor that frequently to make sure you're not losing perfusion to that leg. Okay. How do you think I want to assess their blood pressure? Manually, right? I want the most accurate blood pressure. How often do you think I'm going to assess that blood pressure? 5 to 15. Until stabilized, and usually every 15 from there. Other than palpating pulses to that injury that's distal, What else do I want to assess that indicates perfusion? Cap refill, skin, color, temperature, right? So taking all those things into effect. What about, how can I help circulation? What did you say? Elevate. What can I do to help circulation? Keep them warm.
Compression.
Fluid, what'd you say?
Nothing.
Say, what'd you say?
I just think compression.
I mean, if you needed to. Yeah. But IV fluids, right? If you got an obvious hemorrhage there, it looks like they've lost a lot of blood, go ahead and put an IV in and start some fluids, okay? What is a form of IV that I could do if I'm not able to get a peripheral? IO. Depends on the facility. Bigger hospitals, your ICU nurses are trained to do IOs. In your smaller facilities, usually it's just the healthcare providers that are allowed to do IOs. So just follow your hospital policy based on that. Depends on the scenario and if it's appropriate. You could try it to see if it helps. But usually if it's like a massive bleed, they'll just leave them supine and just crank them with fluids. All right. So what do you think we mean by disability?
Neurological status.
Yeah. Yes.
I'm confused, because I feel like a time on medical, are we re-hospital?
It could be both. It depends. It depends on if you're in the middle of a disaster and you get called, like disaster preparedness, or if you're in pre-hospital, somebody walks in. It will say, it will tell you where you are. It's gonna depend. If you are in public and Walmart blows up, how are you gonna triage the patients that are there since you're a nurse? I'm gonna pretend every single one of you did not answer it that way.
I'm not a nurse that day.
I'm not a nurse.
Anyway,
Just like when I'm on vacation.
I'm gonna pretend all of you did not answer it that way. Anyway,
I don't have what I'm telling
all right. So what do you think we're meaning by disability?
Their level of consciousness.
Their neurological, their level of consciousness. So ideally you want to try to determine their baseline. Are they confused at baseline? Are they nonverbal at baseline? What is their baseline and how are they different from that? Okay. I know y'all covered a little bit of this last week. Again, if they're unresponsive, we need to get ready for intubation to help protect that airway. Continue to maintain your spinal immobilization until spinal injuries can be ruled out. What are some examples of things that can cause disabilities? Overdoses, head injuries from a fall. What about your DKA patients who come in severe metabolic acidosis and we've got to intubate them because their acidosis is so severe, right? So then what do we think about in regards to exposure and their environmental control? So it depends on what type of injury it is, what they were exposed to. Is it a chemical issue? Is it something that needs to be contaminated or decontaminated? With your injuries that come in, like I said, law enforcement has to be notified. So everything that's on the patient has to be preserved. Nothing gets thrown away. So EMS brings a patient in and they've cut clothes to be able to access the patient appropriately. All of those have to be saved and put into a bag. So preserving your evidence, if that penetrating trauma object was able to come out, that piece gets saved. Everything gets saved that's on the patient or in regards to. And then rape kit as well, if it was that kind of trauma. In what cases do you think I would want to decontaminate somebody? Chemicals could, depending on what happened. It's gonna depend on what, yeah. So, I mean, we decontaminate for bed bugs, we decontaminate for mites, we decontaminate for things like that. Right, if they're exposed to a gas, exposed to a chemical, most recent example I can think of is there's a massive accident on the highway where a tractor trailer overturned and gas spilt out on the ground, and he was laying on the side where the gas had spilt out. So he had to come in and we had to decontaminate him before we could do any interventions to prevent injury to ourselves. Usually when these patients come into the hospital or they're coming in, EMS will go ahead and let us know about the need for decontamination, and they'll go straight to the decontamination room. I don't know if you've been to Iredell, EMS can go straight into that room. There's a door from the outside that goes straight into it. So they're not having to go all throughout the ER just to bring them to that one room.
Are we spraying water on people that have contaminated clothes, or taking the clothes out first?
You're right. Yeah, right.
We should have been very thorough.
I don't want to answer that because I know why you're asking me that question.
But no, we wouldn't just spray water on. If I have my work uniform on and I've been splashed with some kind of chemical, like you don't want to just spray water on my work uniform, right? Because it might take down my clothes, my body part. You want to take the clothes off, right?
It's going to depend on the scenario and what happens. On scene, sometimes they may temporarily spray them off until they get into the hospital, and then we take their clothes off and then decontaminate them again. It's going to depend on what happened at your scene and what's going on from there and what type of injury it is. All right. Back on track here. Full set of vitals. What kind of vitals do I want and why are they important? Everything there. Okay. Why are they important? Want to know baseline. I want a trend. Why do I want a trend? Early warnings for decompensation. So if it's a spinal cord injury, could be your neurogenic shock. If it's a hemorrhage, could be your hypovolemic shock. Penetrating trauma, hypovolemic versus septic shock. What are your vital signs trending and what type of shock is it pointing to, if any? Why are temperatures important? Prevention of hypothermia, management of normothermia if able. And then also if they're coming in with a heat exhaustion or heat stroke, bringing that temperature down to normothermia as well. How often do you think we want to do vital signs? 5 to 15 minutes is appropriate. And then as the patient stabilized, you can do them maybe every 30 minutes as that improves. So tell me about family presence during resuscitation. Ask them if they want to be there. Let them be there. Give them the choice to be there. You know, I was going to say, refer to Miss McCarr's Unit 1 PowerPoint. So ideally, you want to do it before the event happens. Sometimes the patient arrives and family doesn't know that the injuries happened just yet. And so maybe some of us are working on resuscitating the patient and somebody's out at the nurse's station calling the family and giving them an update. And as soon as they get there, then they're able to come into the patient's room. So keeping family involved as best as possible. Okay. So another thing we don't think about in regards to family presence is how do cultural considerations come into play? Give me an example. What about a Jehovah's Witness? They don't take blood. So if I have an unresponsive patient who is having a massive hemorrhage and he needs blood, we usually don't think about it in emergency situations. We just go get it and come back and give it. But family being there will help us understand what their culture is, what we need to take into consideration, if they're able to get blood products or not, and if not, what else can we do to help save their life? If you cannot get a hold of family before you do it, then you do it. Mhm. If they've been there before. Mhm. I just had a train of thought, I lost it. What would you say? Oh, going back to the emergency nursing PowerPoint where we talked about consents and EMTALA. So that kind of goes along with consent. If it's an emergency situation, are you going to get consent on this blood if it's a life or death situation? No, you're going to give it to them immediately, right?
How well do, we may have already talked about it, but I forgot, but like, how well do like, say they have a card in their wallet, so they don't want blood, or if they are DNR and they have it there. Does it have to be something signed officially, like with a lawyer involved, or can it be something as simple as that? Or what if they have a tattoo on their neck, it's like.
It's notarized.
Ideally, it needs to be notarized. Ideally, if it's not, and it's just this, it's a simple card, we could go by it, but there's just so much liability because what if he was a Jehovah's Witness 10 years ago and now he's not anymore for some reason, and he just never cleaned out his wallet.
Or like some people on like the medical vans.
Right. Right. So, and that's where liability and issues come into play, and why family is a big proponent, or why we want family involved so they can tell us these things. Sometimes they don't tell us and we do it, and it's kind of like I'm sorry, I did it to treat them. And sometimes, you know, the accidents are so bad we don't have their wallet or anything on them anyway to know. Sometimes, you know, if they have the bracelets, but that limb is affected, that bracelet's coming off. And we don't know when they get to the hospital that it was on or what it was.
Right. Like if it's a do not slip.
Mm-hmm. Yeah. So very sticky situation. But ideally, if it's notarized, that would be the best. But even in that case, they're probably still going to err on the side of caution and give it to them anyway. Yes, Samay.
For example, like the Jehovah's Witness, a man came in and he died. He had to give him the blood, but we don't know whether he is Jehovah's Witness or whatever. We just tried to save him. And then it's showing up that he's a Jehovah's Witness. So
I hate to say, but the prevalence of or ability to get sued is in anything that you do. So is it something that's in the back of your mind when you do it? Yes. But you were practicing in the best interest of the patient in that point in time with the information that you know, and you're treating the patient with the information that you know. Usually family is somehow around, especially in a smaller community like this, families around are able to get to the hospital a lot quicker so we can get that information. It's kind of harder when we have a trauma at Iredell that we stabilize and ship to Charlotte, and the family's now going to drive an hour there. Maybe we don't know the information and we didn't pass it on to the next hospital, and they do something. There's that delay of care there. So it's kind of hard. Yeah. We err in the side of caution, but I mean, you could.
on the hospital can get, not just us, is it only just us or is it the whole hospital?
It's going to depend on the event. It's going to depend on the event. All right. So what kind of monitoring devices do you want to use on these patients? Cardiac monitor, pulse oximetry, entitle. Okay. So under G, you have more letters. LMNOP. L being lab studies. Why do I want to look for an ABG? How well they're breathing. Are they in an acidotic state? Metabolic versus respiratory. What's going on and how can I fix it? Type and cross and the need for blood. And then why do I want to lactate? Sepsis, assess for that lactic acidosis and the prevention of that trauma triad of death. M being monitoring that cardiac rhythm and rate. So if I was hit in the chest, what kind of dysrhythmias would you maybe expect to see that I may have? VTAC, somebody said something else. VFib, what'd you say back there? Could, asystole, depending on how hit you were hurt or how hard you were hit. A lot of times when you're in a car wreck and that steering wheel hits your chest, asystole, PEA. Maybe in your healthier patients, they may throw some signs that their heart's angry, and what would they? PVCs, right? PVCs are kind of cluing you in that something may be happening or something may getting ready to be happen or may be getting ready to happen, and just kind of keeping a closer eye on that. What other changes do you think I may have if I get hit in the chest? Ischemia, meaning what kind of changes? ST elevation, may have ST depression. Could. Going into, maybe you develop tension pneumos, maybe you go to PEA, cardiac tamponade. Thinking back to those items from unit 1 and 2. NG and OG tube, why would those be important? Decompression, and what else? You may not know it yet because it's in the next unit. Next, PowerPoint. Med administration, if it's an overdose and you need to give like activated charcoal or do a gastric lavage, you could use it for that. If they have a facial trauma, facial fracture, facial trauma, facial swelling, or a severe head injury, where do I want to place my tube? NG or OG? OG. Why? Could possibly go into the brain. Oxygenation, we're going to look at end-tidal CO2. What's your good range for end-tidal CO2 to show perfusion efforts? 35 to 45. And then pain. How are we going to assess pain in your trauma patients? So that's your sedation. CPOT. So if they're ventilated versus non-ventilated, there's 2 different forms of CPOT, and that'll kind of tell you what their pain is, and allow you to treat it from there. So why is it important to control pain in your trauma patients? What does pain increase the use of? Increases that myocardial oxygen demand, right? So increased heart rate could possibly have an increase in blood pressure. That pain and anxiety is going to cause that release of the epinephrine and norepinephrine, that fight or flight syndrome. So controlling the pain and doing your pain scales every hour is going to help prevent those things from happening and help prevent that increase in that myocardial oxygen demand. All right. So now we go into our secondary survey. So secondary survey, we're going to get a patient history and do a head-to-toe assessment. So you talked a little bit about sample last week with Miss Stoig and Burns. This is what symptoms were associated with the injury. What happened? How did it happen? When did it happen? What were you doing when it happened? What allergies they have, any medications, especially anticoagulants we want to know about, right? Because of that increased risk for that coagulopathy. What's their past medical history? Are they having severe chest pain and we need to give nitro, but they're taking medications for pulmonary hypertension or ED? We need to know about that. When their last oral intake, and last oral intake is important because if you go for intubation or unresponsive, you worry about aspiration. Last output to kind of understand why perfusion efforts are helping. And then a female client for their last menstrual period to understand childbearing age and understand if you have time to get a urine pregnancy test or not. And then events and environmental factors. So did you pull out in front of another car? Were you riding a scooter and got hit by a car? What were you doing in that environment that happened? So you're going to do a full head to toe assessment. And then you're also going to do what's called a FAST exam, or the provider is going to do your FAST exam. So what's the FAST exam going to look for? It's going to look for fluid in the abdominal cavity, the perineum, and the thoracic cavity. If there's free fluid, what does that possibly indicate? That there's bleeding somewhere. And where do these patients need to go? OR or a trauma surgeon. Okay. When I do a full head to toe assessment, I'm looking at eyes. What do pupillary changes going to tell me? Maybe if there's head trauma, what the neurostatus is. If I'm having increased ICP related to the trauma or the injury that happened. I'm looking at ears. What are ears going to tell me? CSF leak. Maybe there's some blood leaking out of the ears. What happened? In kids, if they get hit in the head or they have a severe head trauma, they could have bruising behind their ears, and that would be priority then. What about your nose? Same thing as the ear, CSF leak, your clear drainage or your bloody drainage. Foleys are important for your trauma patient, again, because you want to look for those I's and O's. Make sure your perfusion efforts, your fluids, your vasopressors, whatever you're giving your client is A, coming out, or B, your kidneys aren't getting affected. So I know this goes against everything we tell you in nursing school, but you're going to look at their backside last. Okay. So a lot of times you'll see patients log rolled so the provider can assess their back. You'll see the provider kind of palpate along the spine, the shoulder blades, just to see if there's any obvious deformities that they feel. So contrary to belief, log rolling can be dangerous, especially if that C-spine is not supported. Maybe they have a C-collar, but the C-collar is not on right. You still need to hold that head in a neutral alignment when you're turning the patient to assess their posterior surface. What is another important aspect of the posterior surface that needs to be assessed in regards to your spinal cord injury? Sensation. What'd you say?
I was saying, spinal cord is private, but if it's the back, it's
rectal tone, right? So that decrease or that absence of rectal tone could indicate a spinal cord injury. So when I talk about rectal tone, what do you think that means? Yes, the ability of your muscles to clench, right? To activate. So if you have an injury there, those muscles aren't going to be able to activate like they need to. So that's important to assess. And then J, just keep reevaluating. You're going to keep going through all the things that you've done. Make sure that you're doing your vital signs. You're continuing to assess their pain every hour. And then reassessing your interventions that you did for those injuries. So disposition, depending on what happens, these patients may be able to go home. Maybe I was playing kickball and I tripped and fell and I broke my ankle. I can get a cast, splint, and just get orders to follow up with orthopedist outpatient. Maybe I am in a small community hospital and I was in a major car accident and I have a positive seatbelt sign and a distended abdomen. I need to be transferred for surgery, right? If you have the ability, a specialty ICU, usually like a trauma or a surgical ICU, depending on what happens. Specialty intermediate care unit, meaning, like a trauma step down to where they're not so bad that they need to go to ICU, but they're not stable enough to fully go to the floor. They can go in that intermediate spot. Unfortunately, death is another disposition we have to think about, right? So traumas being CPRs in the field that get brought in, you continue efforts for resuscitation and they don't make it. Unfortunately, they pass away. That is a disposition. So very basic, very brief assessment for trauma. We're going to cover more next week when we talk about the disaster preparedness and we talk about MCI and start triage. I will post the recorded lecture for the environmental and toxicology emergencies, like I said, by tomorrow by 9 a.m. And I'll post an announcement when I do for you. Okay. So any pressing questions before we go to lab?